Welcome to Med Supervision Initiative. For today's session, we are looking at part 1 and we have a task there which is looking at discuss the diagnostic criteria in classification of acute kidney injury. It's a very important topic here, and for whether you're writing final exams or intermediate examinations, it's a very important question in renal medicine. Okay, so most of the lectures have been recorded. Please remember to like, to subscribe, and share so that whenever a new lecture is posted, you are also updated. Let us grow this channel together. Okay, we can begin now. We begin with always Sir William Osler. You know, he's one of a very good model for internal medicine. And he said to start the phenomenon of disease without books is to sail uncharted sea. To start books without patients is not to go to sea at all. So meaning that as we are running our revision, our mentorship, it means that we are trying to balance what does the book say and what you're likely to see when you are in the field, when you are in practice, and when you are preparing. Also, trying to balance on what is the must know that you're supposed to know whenever it comes to the aspect of preparing for the exam, so that you know what's supposed to prepare, what's supposed to study, what a must know, and specifications that you're supposed always to know. Let's begin with as you can see there. So we are looking at the kidney, and that is one of our area of interest. So let's begin on the members. What are the key areas that at the end of this session you're supposed to achieve? Number one, we are going to review some terminologies that are used in renal medicine. Okay, and also we are going to contextualize the clinical features in the given problem-based learning, especially the scenario that we are going to meet, and we are going to contextualize so that we are able to unlock the hidden aspect on scenarios, because most of the students, they are very scared, they worry whenever they see a scenario. Okay. Also, we're going to formulate the differential diagnosis for the given problem-based learning that we are about to see, and then make a definitive diagnosis from the scenario that we have been given. And then we're going to discuss the diagnostic framework with interpretation for this patient, rational, precise of lab, imaging orders based on the level of healthcare services. Although this one will be more discussed in part 2, where we are going to talk about comprehensive management, that will look at the pathophysiology of AKI, we'll look at the clinical presentation in detail on the features and how you can identify them, how you can interpret them, with investigations based on the level of healthcare from healthcare from health center to a third line hospital. And then that's what we're going to do in part 2, because in part 2 we're also going to go in detail on the principles of management, treatment, posology, and managing of complications. But in this discussion, as you can see, it's underlined with more to do with the availability to discuss the variable criteria for classification of AKI. That's a very important question in the exam as well. Even in practice, it will help you, because everywhere where you go, whether you are in gynecology domain, surgery domain, pediatrics domain, even these other special subspecials of medicine of domain, as well as the borderline of the hub of medicine practice, internal medicine, you are going to also to meet acute kidney injury. And if you go into subspecialists, the proper hub where you are able to get to know to the nitty-gritties actually is a nephrology. So that is what we are going to do today. Okay. Now we can begin that at the end of this presentation, at the end of this lecture, you have to demonstrate clinical competences in the way you have been evaluating the patients that are presenting with acute kidney injury. Okay. That is very, very important. Let's begin now with the problem. So we have case study 1. Okay. You are in the emergency room doing your last call for 2022 when you receive a 20-year-old boy complaining of 1 day duration of inability to pass urine despite taking a lot of water. Difficulties in breathing, body weakness, and severe diarrhea, which he has had for 2 days now. Denies any history of sore throat or change in color of the skin. Okay. So now, before you can even proceed, I always say that before you can proceed to go to the next level of questions, because sometimes you want to start answering questions without having a broad picture, without unlocking what is hidden, what is this scenario talking about, what is the situation in this scenario. So let's begin now. Okay, so let's begin by highlighting. Okay, so we begin. What's the problem first and foremost? This is actually a boy. Okay, how old is the boy? Is 20-year-old boy. So first we have identified the patient that we're dealing with, a boy who is a male and 20 years. And what's the problem? The problem is inability to pass what? Urine. So inability to pass urine, we know the kind of a system now we're talking about. So we can even identify here that actually we are now talking about genital urinary system. Or we can see that we have opened the door to renal medicine. Okay. Now, this person, for how long has this problem been there? It's just for 1 day. So we have answered, is it a chronic or acute? So we can see that actually it's an acute condition. Okay. So it's an acute condition of what system? Of urinary tract system. Hope you are following. Now, what could be the problem of this nerve system? Because we know someone may be thinking that actually in a bit to pass urine, not able to pass urine, maybe through other causes. It's either you do not have fluids in your body, you do not have enough water. Now, this boy has been taking a lot of water, not just taking water, but a lot of what? A lot of water. Okay, so this boy has been taking a lot of water. Then, so regardless, despite taking a lot of water, this boy is unable to pass urine for 1 day now. All right. Then what other things that are there? There is difficulty in breathing. Okay. So what do you think could be the issue of difficulty in breathing? So you can see that since there's attack of the nervous system, I would think that, okay, I think this difficulty in breathing could be due to acidosis. Okay. Maybe the oxygen concentration is low. All right. So you're able to look at all those areas. Okay. Then there is body weakness. Okay. So I have to pause. I cannot rush. Okay. What could be the cause of body weakness? Let's see why this boy is feeling weak. Okay. Then, and severe dehydration. Not just, severe diarrhea. Not just diarrhea, but severe diarrhea, which he has now for how many days? For 2 days now. Okay. Then, from this history that this boy has denied to say, actually, I don't have any history of what? Sore throat. So, this boy has denied. And we know why the question is talking about sore throat. Sore throat is talking about streptococcal infection, because streptococcal infection may cause post-streptococcal glomerulonephritis. So that's why we are even able to rule out there. At least, okay, that's why maybe they're trying the examiner is trying to push there to think in that direction. Then there is no color, no change in color, skin. So meaning that actually at this level, okay, it's very acute. So we haven't, because no change in color, because they want maybe to us to forget about it. We know that there is change in color when it comes to the problem, acute problems that are due to do with the urinary tract system. Okay. So from here, at least we have addressed now. We have seen that diarrhea, severe diarrhea has been for 2 days. And because of this 2 days diarrhea, we are able now to begin as that objective that we say, let's start to contextualize now what is happening. Because of severe diarrhea here, now I understand why this boy is weak. Because we know that in severe diarrhea, it causes what? Dehydration. And in clinical medicine or in internal medicine, it's not just enough to talk about dehydration. Because we have to talk about 3 types of dehydration. Major dehydration. We have got hypertonic dehydration, we have got hypotonic dehydration, and we have pneumotonic dehydration. So from this aspect here, we have seen that what we have here is the pneumotonic dehydration, or it is called the isotonic dehydration, or isosmolar dehydration. So this type of dehydration is very important in this aspect. Okay, so the type of dehydration, why pneumotonic dehydration, what is the problem when there is pneumotonic dehydration? Problem number one, when there is pneumotonic dehydration, what we are able to see that actually there is extracellular fluid depletion. And we know that the extracellular fluid depletion actually affects the cardiac output. Okay? Cardiac output, I think you have done cardiovascular medicine for those who have been following the lectures. Okay? We say the cardiac output actually, that's the amount of blood that is pumped per what? Per minute. Okay? In other way around, we are saying this cardiac output that I've mentioned is a product of what? Heart rate and stroke volume. Okay? And that's how we come up with what? Cardiac output. And the cardiac output, why I've mentioned the cardiac output actually is the one also that is contributing or dependent, or is a factor that increases or decreases blood pressure. Okay? And not only that, when we look at what's happening here on the extracellular fluid compartment depletion, it means that even the glomerular filtration rate again is affected. Because I'm sure you're able to remember, if you listen to my lecture number 1, intro approach to renal medicine, I said that actually when we talk about the urine, where to drive you back to your basic sciences on urine formation and renal physiology, I said when we talk about this aspect of cardiac output, extracellular fluid compartment being depleted, or low or loss of fluid in this compartment, you find that actually we know that per minute from the cardiac output that I've mentioned, which has reduced in this aspect, 20% to 25%, okay, of cardiac output per minute goes to where? To the kidneys. Okay, in this aspect I'm talking about both kidneys per minute. And then we have to ask a question, how many liters are we talking about if we are saying that? Just to analyze, let's move together, dear friends. It's very interesting that we have to understand, don't need to memorize scenarios. Okay, so if we're saying 20% of 5 liters, then we're talking about 5,000 mils. So it means it will give us what? It will give us 1 liter. Okay? And we know the principle that out of this 1 liter, 60% actually is we have fluids, and 40% there we have what? Solids. That's where we have the cells. Okay? So now 60% of 1 liter, it gives us 600 mils. Then this 600 mils, 20% to 25% of this 600 mils is filtered per minute. Okay? And when we say 20%, for example, let's take 20% of 600 mils. What are we getting from there? Okay? What we are getting from there, it is 120 mils per minute. And this is what we are calling glomerular filtration rate. Hope, dear friends, there we are following. This is what we are calling glomerular filtration what? Filtration rate. So this is the link. Okay? This is the link. So that's why this thing is compromising. And now it is that even when we are going to start looking at what other inquiry am I going to ask, I have now a direction. So from this direction that I have is that this direction now I'm suspecting to do with this condition, an acute condition that has to do with the what? The renal function system. Okay, so there is already a disorder here of the renal system, general system. The renal system is being affected, and that's what the problem is. So this is how we come about. So when you're reading in your books that 120 to 125, you should know how the 120 is coming about. Okay, that is how we calculate, right? Then we can now see that what came first. Okay, what came first between the diarrhea and the inability to pass urine? So what came first is the diarrhea. Okay, because it is 2 days now. Then this problem of unable to pass urine is 1 day. Okay, so keep that in mind as we progress. Okay, so now from here now I have a direction. So A, what other information would you want to inquire from history? That now I have unlocked, I'm able to see. What are the differentials now? I'm able even to start to answer what could be the likely cause. Okay, what are the likely causes of this condition, this situation? These are what we call differential diagnosis. And in the exam, right, for example, in IMED, you're not supposed to begin like you're most likely, supposed to list them. At least if you cannot manage to put them in order in the way they're supposed to appear. If this one, I think the second, more opportunities the second one. At least know the first, the most likely, and you have to put it on number one. So it means that if you are able to know differential diagnosis properly, then even the most likely diagnosis, because the most likely diagnosis should be picked from the differential diagnosis. And it is very wrong to pick a most likely diagnosis outside from the differential diagnosis. Okay? That is very important to take note. Very, very, very important to do what? To take note. Let's proceed now. Discuss the specific and support investigation in this patient. And that's what we're going to discuss. And D, what's the most likely diagnosis? If you've answered B, even D is straightforward. And E, our main concern, our main tune, our main chorus for today, discuss the classification criteria for D. So for D, that's the most likely diagnosis. Right. Let's proceed now. Let's see. So inquiry from history. Number one, it is fever. So fever, I want to look at the infection. Okay. So fever, I'm thinking of an infection just because I know that any infection may precipitate the complications of the renal system. Okay. Second, history of sore throat. Now, I've put it in blue. Why? Because this patient that we are discussing refused, denied to say, I have no that history of sore throat. But if it is not cited in the scenario, it's very important to ask about sore throat. Because sore throat, I'm having in mind that this one, it may result into what is called post-streptococcal glomerulonephritis. Okay, that's why I'm thinking about that. So even when I'm looking at the history, I'm supposed to be focused, not just about asking anyhow, somehow, because there's history. Okay. The third point is history of bleeding under the skin. So this kind of hemorrhage, this kind of bleeding, I should think that actually this can be, I should be thinking in mind of what? Uremia. Because uremia is able to impair the dysfunction of the platelets. Okay? And if the platelets are dysfunctioned, the platelets are destroyed, they are damaged, they are reduced in number, it means there will be a problem with the bleeding. Okay? So you have to be very analytical. All right. Hope I'm making things very simple here. Then the other thing also, this bleeding also may lead to anemia. It's also one of the reason why this person may also be weak, because it's losing what? Blood. You know that kidneys are also responsible for production of erythropoietin. And you know the relationship of erythropoietin and production of red blood cells and increasing the hemoglobin concentration. And you know that if the hemoglobin concentration, the number of red cell mass reduces, that will result into what? Into anemia. And that, of course, one of the clinical features that the patient may present is weakness. Okay, so as I'm asking, I have a direction because I have already unlocked. Then I have to also inquire on the history of cough. You know, cough is not a diagnosis per se, but it may tell me what kind of cough. And if you go back to my first lectures on approach to internal medicine, approach to history taking, to clinical methods, I think I've explained even how to do a good history taking just specifically for fever. Because some they get confused. If they are just told fever, they are stuck. They don't know even how to do a history taking of fever. Okay, what to look for? All right, you just know, oh, fever equals malaria. So no malaria, you are confused, my brother. All right, but again, we come down to cough. So cough also, we have to analyze what type of cough, for how long. Okay, because it may be signifying infections. Okay, that have a relationship to do with, to affect with what? Kidneys. And some of these infections, again, indirectly may reduce the oxygen concentration and increase the acidotic state of the blood, which at the end of the day, this blood again is going to pass to the kidneys. And if these kidneys are receiving acidic blood already with a lot of acidic state, it may also result into injuring the kidneys. Okay, so as you are trying to inquire, you are thinking at another level, that is being a clinician. Okay, that's being a diagnostician, right? Then also look at the diabetes mellitus. Okay, I always say that when you're just talking about diabetes, you know there's diabetes insipidus and diabetes mellitus. So I'm more particular to talk about diabetes mellitus. And diabetes mellitus, why am I trying to look up? Of course, don't complicate things by asking too much the patient to say, are you diabetic? You know, someone just tell them, are you diabetic? Do you have diabetes mellitus? They'll run away thinking, doctor, what are you trying to tell me? What kind of disease now am I having? I already have headache, then you're also bringing up these big diseases. Am I going to survive? So find a way, because you may miss otherwise. Diabetes mellitus actually is popularly known as sugar disease. Okay, so some they easily understand when you tell them sugar disease. Okay, so diabetes may have a complication that is called diabetic nephropathy, and diabetic nephropathy may damage the kidneys. Okay, so that's why I'm trying to inquire. Okay, and that's another way where I'm going to look at the increased appetite for food. I know this could be one of a metabolic problem, endocrinological problem. So I'm trying to inquire, and these are the inquiry from history that I'm trying to get. And remember, HIV status. Someone may be, but you talked about fever being an infection. Yes, it is. At HIV is specified, it's treated as a very special, what? Special infection. Okay, so it is also able to cause a lot of complications to do with what? Renal. And not only that, on the same history inquiry, I'm also supposed to look at the smell of the stool, because there is a history of diarrhea there, the color of diarrhea, how many times, okay, he has had this diarrhea episodes per day. Why am I asking these questions? I want to look at severity. How severe is the diarrhea? I want to estimate how much food has been lost, so that I know when it comes to replacement. Okay. You may also inquire about TB, tuberculosis, because also it is able to affect the kidneys. And another important one, very, very, very important one, you need also to inquire on the drugs. If you want to be smart, in IMED, I think it's about the drugs. Because you have to be responsible, you have to be very cautious on every drug that you are prescribing. Okay? Every drug. Is it nephrotoxic? Okay? Is it dangerous to the kidneys? Don't just prescribe. Don't just look at the dosages. Okay? You have to really care on the patient. So, drugs also can contribute. And always, and you know our state in developing countries, we like actually taking drugs on our own. Because these drugs are simple, I can access diclofenac, ibuprofen, just take them, okay, without even engaging. Some even say, why should I go to the clinic and make a queue when I know what I can use? But the clinics are not meant that even if you know, you shouldn't go there. Why you go to the clinic is you are going to see a clinician, or a patient is able to come and see you as a clinician for you to say, yes, you need a drug, or you do not need a drug. And that's what is important. Anyway, let me not go in that direction. So drugs, very, very important. Okay, so hope you have we are moving together there. Okay, let's proceed. Now we come to the differentials. What comes in your mind? Yes, raise up the hand. What is your mind now? We have developed a roadmap now. We have a direction. What do you think are your differentials? Very good differentials. Close differentials. Okay. Hope you are thinking this one. Number 1, acute kidney injury, secondary to severe dehydration. Why have we written acute kidney injury, secondary to severe dehydration? We know that what came first there was diarrhea, severe diarrhea. So this severe diarrhea has now resulted in severe dehydration. And this severe dehydration resulting into concentration of constituent, concentration of chemicals. Okay, so the solids being concentrated. Okay, this is making concentration of toxicity. Okay, is leading to what? An injury. So it is number 1, and you know the principle I said number 1. The second one is hemolytic uremic syndrome. Is one of another important differential diagnosis. The third one is post-streptococcal glomerulonephritis. So this is why we're asking about a history of sore throat. Is another important differential diagnosis. Okay. Diabetic ketoacidosis. Okay. It's also a very important differential diagnosis. Severe malaria. Okay. Now, listen carefully. So, we have now outlined, we have answered task B now in terms of different diagnosis. So, even now, when you'll be looking at investigations, they should be also able to answer, to rule in or to rule out. Because now, when I draw up different diagnoses, for me to come to the most likely diagnosis, I need so many skills. Number 1, I have to do the assessment. That's very important. So, you know that the formula here, for you to be comprehensive, it is history taking, okay, plus physical examination, plus investigations. And we know that from history taking, I'm getting about 70% alone. I'm able to make a diagnosis from history taking. Physical examination is able to provide me about 20%. Investigation is able to provide me about 10%. That's why it's a confirmatory part. Okay? I've heard some people just send people to the lab and say, oh, we are sending you to the lab, but we test everything. I don't even understand what they mean by everything. So you have to have a direction when you are ordering as a clinician. So ensure that history taking is focused, and you have seen how we have made it so easy for us even to look at the differentials, because our history taking, we have concentrated it, we're able to inquire it from very well, we have to have good directional questions, and then from there we have to do the physical examination. So History taken plus physical examination, we are going to have 90%. And 90% now, we have to confirm. And confirming meaning that we're going to order appropriate investigation so that we confirm what's in our mind. Otherwise, if we just send the patient to the lab and do a battle of investigations, when these investigations comes, what we just end up now doing is just getting a pain. Abnormal, normal, abnormal, normal, abnormal, normal. We're just marking and we don't know what we are looking for. Yeah? So, dear friends, let's move together. Okay, so remember what I said, what's a likely diagnosis? Because whenever just we set in an exam, so in an exam, you write like that, my friend, you are well to do in the exam. Okay, then like diagnosis, you know, wow, it is what? Acute kidney injury secondary to severe dehydration. So we've already known now we have already known what? The aspect of uh, the likely diagnosis. Let's go now to the next part. It's a part of investigation. And remember that investigations here are only being used to make a confirmatory diagnosis. Okay? This is what we call evidence-based medicine. Right? I have now to confirm, to narrow my differential diagnosis. Okay? So, do number one is serum creatinine. Okay? So, serum creatinine is one of a diagnostic thing because I'm now looking at the aspect of what? The kidneys. Okay. Urine examination. So there's urine, routine, microscopic, culture, and sensitivity. What this simply means that it's not just mandatory that every patient have to order urine, routine microscopy, and have to do the culture and sensitivity. That will determine on how the condition is. Maybe I've been managing this patient and it's not responding. So I want to know if the drugs I'm using are sensitive. Or I want to isolate the organism. That's when culture is much indicative. Now, just even urinalysis. You know when I talk about urinalysis, okay, urinalysis simply means chemical analysis of urine or biochemical analysis of urine. That's why you use those strips, okay, that have 10 parameters. I'm sure if you want to get more, you can listen to the first lecture's approach to renal medicine, where I've explained on every investigation. Okay. So now here, if you happen to use a dipstick, then you find that leukocytes and nitrates are positive. In this patient that we're talking about, what that would indicate, it will tell you actually there is what? There is infection. Okay. It will tell you there is infection. This one is more to do with what? The kidney injury. Okay. So, I said when there is a leukocyte, okay, that's WBC, okay, and then plus the nitrates. When these are positive, it is showing you that there's an infection. Also, what other thing can I also tell you? It is blood. When blood plus proteins are present, are positive on a dipstick, that's actually telling you that is a glomerular disease. Okay, so you have to know, and these are the key areas that you have to make a quick decision, especially if you are working at a rural center. Okay, then microscopy. Okay, microscope actually you are looking for casts, you are looking for crystals, looking for cells. Okay, and then you have to also give you about the infections. What other thing are you going to look at? Stool microscopy. Okay, culture and sensitivity, remember, it's not routine. It depends if I want to isolate. Okay, and I want to know the most sensitive drug. So why am I doing stool microscopy? Because of from the history, I've been told that actually he has severe diarrhea. So I want to address what type of diarrhea, what kind of organism, what's the causative agent. Okay, and I may go further to also look at the most sensitive drug that is required to treat. That's why I'm ordering stool microscopy. Electrolytes, okay, even plus urea, okay. Why am I doing this? I want to look at the urea electrolyte imbalance or dysregulation. Okay. And sometimes I may also check for hyperkalemia because usually this is a very common and important complication. Okay. What else am I going to look at? Full blood count. This is very important. And this, when you're ordering this, don't just waste all those parameters that are on the full blood count slip results. So I have to think of WBC there. White blood cell, even the differential count. I also need to look at the red cell indices. Okay. So there I'm talking about the HB, very important. I'm talking about the mean cell hemoglobin. I'm talking about the mean cell hemoglobin concentration. I'm talking about the mean cell volume. I may also talk about the red cell distribution width. Okay. So I may also talk about the red cell count. So when I'm looking at these indices, they will help me actually even know, because as I said earlier on that there may be bleeding. You know that when kidneys are affected, erythropoietin may be also affected. Okay. Not only that, also when bleeding is too much, the platelets are being dysfunctional when there is secondary to uremia. Then I have to come and classify what kind of anemia there. So I'll look at what? HP. And then look at what? The indices. So that I can know, is it microcytic? Is it nomocytic? Is it macrocytic? Okay? So that's what it is. Then the white blood cell, I'm trying to look at the what? The infection. And sometimes I may also, the differential count will help me to narrow on the infections that would be suggestive in this situation. That's why I'm ordering full blood count. Okay. But in an exam, if the question is outlined, then you just list them the way they have been listed. But I'm just trying to admit that you understand, because you do not just list investigations in the patient's file. Okay, you end up actually getting more confused than you thought before ordering the investigations. All right. Then you may also order random blood sugar, fasting blood sugar. Now, here in the situation of this patient, we do not know, so not wait to say, oh, let's wait the patient to fast, then we'll do the fasting blood sugar. We will do just there and then the random blood sugar. Okay. What we need to know are the ranges. So the random blood sugar is 3.6 to 6.6 millimoles per liter. Okay. So we know that fact, that actually 6.7 up to 11, that is pre-diabetic. Okay. I think you are going to enjoy when we begin endocrinology. And then when it's above 11.1 or equal 11.1 and above, that's when we say now there is marked hyperglycemia here. So what are we trying to rule out? You want to rule out diabetes mellitus. What of in a situation of fasting blood sugar? Fasting blood sugar is 3.5 to 5.5 millimoles. You know, these are units I'm using are millimoles per liter. So you know that from 5.6 to 6.9, that is pre-diabetic. And above 7 millimoles per liter in fasting blood sugar, that's marked hyperglycemia, which may be suggestive of diabetes mellitus, based on the, of course, by combining with the clinical features. Okay, so hope you are now getting what why we are investigating random blood sugar, fasting blood sugar. Okay. The other one is BS for MPS. I have a problem here. There are some who just want even to write BS. Who say the blood smear is for malaria. Because I can also do blood smear just to study the picture of the red blood cells. I can use blood smear to know the picture of the red blood cells. Is it pale? Are they big? Are they small? Are they in normal size? Just using a smear. So you have to be very specific when you're writing. You have to be smart. It's blood smear or blood slide for malaria parasites. Have to be very suggestive, to be very indicative, because we know that malaria is able to injure. At this point, I want to tell you that when we're talking about acute kidney injury here, it's also very important that we have to know that there is pre-renal, there is renal, and post-renal. So what we mean by pre-renal is before the kidneys. And what could be the problem? The problem in pre-renal is actually volume depletion. So it is to do with the reduction of perfusion. So it is a perfusion problem, secondary to hypovolemia. Okay? Then it may be renal. Renal simply means now it's inside the kidneys. Themselves, the kidneys are the ones that are having the problem. Sometimes we even call them intrinsic. This is where now malaria can come in here. It can damage the kidneys. Okay? So that's why I'm trying to also rule out severe malaria may be responsible, so that I can quickly remove. RDT also. Do not just write RDT and you are happy. And you write, who said that RDT is for malaria? There are so many RDT. RDT that stands for rapid diagnostic test. So don't be operationalization unnecessary. Be smart. Okay. So write RDT for malaria. Okay. And I actually discourage students to be writing in jargons. Okay. Treat examiners as if they are layman people. Write in complete, and if you are too smart, you want to show them that you are too smart, put them in bracket. Full blood count in bracket. Eh? Maybe we may have some of you are in USA. Eh? You write for us complete blood count. CBC. Yes. Now, all right. So RDT, and here I'd love to. It's another lecture anyway. You can go to another lecture on approach to clinical management to malaria in a clinical setup, because here we have also a problem. Some of the clinicians actually do not know how to order RDT and blood slide for malaria parasite precisely, okay, rationally. What they just know is RDT, 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 RDT. Okay, let's try to move, especially for you as a student. If you want to become a very good clinician, an excellent clinician, you have to be very smart whenever you are doing something. You have to be so analytical. So these RDT actually are impregnated either with histidine rich protein 2 or lactate dehydrogenase. Okay, so the histidine rich protein 2, like in Zambia setup, the old ones, they were taking 35 days to test reactive after successful treatment. Okay, the recent ones now, they are taking up to 14 days. And then if you happen to use the lactate dehydrogenase, then they take 5 days after successful treatment. They have to test non-reactive. That's very important, but it's another lecture that you can also listen to if you really want to understand on the approach to malaria, even how to manage malaria in all age groups, especially from health center up to a bigger hospital. Right, now, these RDTs especially, I like asking a question, even if it is under renal. If it's RDT for malaria, what are the two major indications? Indication number one of an RDT actually is to confirm for the diagnosis. Number two, it's to confirm your clinical diagnosis. In a situation that you treated the patient, all right? If you're using histidine-rich protein 2, you have treated the patient within 2 weeks. And then after treatment, 3 days of completing a mefantrine, popularly known as Coartem, then the patient comes back. You tell the patient to come back after 3 days. You may test. If RDT becomes non-reactive, it means your diagnosis was wrong. So if it becomes reactive, then you know that actually your diagnosis was correct for malaria. Okay. and you can only confirm that to evaluate using blood smear for microscope microscope malaria for blood slide for malaria parasite examination. Then if you are using the other part, the other indication, I think I've mentioned about two. All right, so that's very important. Now the RDTs, okay, the RDTs should be supported with history taken, not in isolation, because you may end up treating a patient who is already on treatment or has been treated already. Okay, the other one is the ABG. So you know the ABG, that is arterial blood gases. So the arterial blood gases, you are trying to do what are you trying to do? On the arterial blood gases, you are trying to look at one, the partial oxygen concentration. You are trying to look at the partial arterial carbon dioxide. You may also talk about the bicarbonate there, okay, and you may also talk about pH. The question of this is just to address acidosis. Is there acidosis or there is alkalosis? And we know the major problem there is we want to rule out acidosis. Okay. I always ask a question. What type of pH here are we talking about? Is it intracellular pH, or is it extracellular pH? Which pH are we testing? Hope you're not telling me it's intracellular pH, because intracellular pH is neutral. The pH is 7.0. But extracellular, it is 7.35 to 7.45. Another important question over pH, okay? What is the range of pH that is compatible with life? Very important for clinicians. That is 6.8 to 7.8. So meaning beyond 6.8, what you find there is what? Is death. All right, let me write for you. I like providing concepts. You need to understand concept. That's a real major purpose of this program. It's not about passing. What you have there is death. And beyond 7.8, what you have there is death. So pH compatibility with life ranges from 6.8 to 7.8. Okay, so I've explained there on the arterial blood gases. The next one is antistreptolysin or titer. What are we trying to look there is we want to look at streptococcal infection. Okay, and we already talked about the post-streptococcal glomerulonephritis. The other one that you may also do to rule out streptococcal infection, you may also do the deoxyribonuclease B. Okay, you may also do the anti-hyolidase. You may also do those investigations. All that can also help you to address the streptococcal infection. Drug history, very important. Okay, such drugs that always should be, I think, like in our setup, like Zambia, mostly I think the ibuprofen, propranolol brufen, these naproxen. We may also talk about aminoglycosides like gentamicin. These are actually injurious to the kidney. So you want also to do the drug history. Very important as a reminder. Urine catheter. Why are you doing urine catheter? Okay. Urine catheter is giving us two things. Two important things that we should be thinking about urine catheter. Okay. This is another lecture. I think you can also go to approach to renal medicine, where I even talked about indications of catheter, types of catheter that are there in clinical practice. Okay, so now in the why in this aspect in this patient, one, it is also diagnostic, and I will explain. Then it is also therapeutic. So it's able to relieve the patient at the same time. At the same time, in this especially here, I'll pick more of the diagnostic, because most of the patients that present with acute kidney injury actually are admitted in the ICU. So what Pute will do the catheter and connect also the urinary bag. So when we check the urinary bag, we'll be able to check the urine output. So this is what is going to tell us. Okay. So this will help as we are looking at the input-output chart that we are trying to observe in the ward. Then we are seeing what we are putting in as fluids and what is coming out. So this is aided using a urinary catheter. Per-rectum examination. Okay. So per-rectum examination, what are we trying to really look at there? It is benign prostate enlargement. Okay. So benign prostate enlargement, it can now cause what? Post-renal. It can obstruct, okay, and lead to accumulation. And these can be examples of BPH. You know, BPH can be benign prostate hyperplasia or benign prostate hypertrophy. That's why benign prostate hyperplasia or benign prostate hypertrophy, you cannot diagnose it clinically. Say, no, I think this is BPH. Yes, say the likely could be BPH. But say benign prostate enlargement, because BPH actually can be diagnosed on histopathology, because I'm talking about the cells here. How am I going to know they have increased in number? How am I going to know they have increased in size? Okay, so we have to be very smart, right? Yes, so the bottom line is, take-home message, per-rectum examination is helping a clinician, it's helping you actually to rule out an obstruction that can be a result of BPH, which is it, and resulting into benign prostate enlargement as obstructing. Okay. Abdominal ultrasound or CT scan. Okay. So practically we begin with a cheaper non-invasive investigation, which is an ultrasound scan, and an abdominal ultrasound scan or pelvic ultrasound scan is helping actually to differentiate if there's between an obstruction and hydronephrosis. So an obstruction can be there. Hydronephrosis is actually dilatation of the ureters. Okay. So when there's dilatation, meaning there's narrowing, there's stenosis. All right. So that's how this can help you actually to differentiate. Again, it can also explain to you the sizes of the kidneys. And if it shows you that the size are smaller, especially less than 9 centimeters, then that tells you that actually that is a chronic what? A chronic kidney disease. So that's problem which is actually a long problem that has been there for long. So it is a chronic condition. So an ultrasound scan is able to help you to look at the structural anatomical framework, okay, and locate where the problem is. Okay. Then we may also do renal biopsy or urograph. Renal biopsy actually is where you talk about renal intrinsic, okay, because there may be some carcinomas that may affect the kidneys. All right, so that is what you have to do when you're talking about investigations. Now, let me take you back to certain things that's supposed to know, very important. So let me try to wrap with this part so that you see what I'm trying to explain here. Okay, because when you are doing an investigation, you need to know some of important normal ranges or concept. Otherwise, you may fail to do what? To interpret. Okay, so let's begin. Number one, let's review. Always let's know this, at least know this normal urine output. Okay. So for us to know, because these are the key areas that we're going to discuss throughout the study now. So the normal urine output, what's the normal urine output? So normal urine output is from 0.5 to 1 ml per kg per hour. Okay. Now, that's what we are calling normourea. Now, listen very carefully. Here, we have to define, we have to also talk about these terms. Okay, we have normourea there. Let me try to change the pen. Okay, we may talk about normourea there. We may talk about oligourea there. We may talk about polyuria. We may talk about anuria. Okay, so that is very important. So when we talk about that, I think when you go back to my lecture number 1, I've explained on urine formation because that's very important. But to summarize, we know that comes from the cardiac output, goes to the renal system, 20%. Okay, then filtered there, we have the glomerular filtration rate. Goes down into the nephron, we have the fluid that have been reabsorbed. About 99% being reabsorbed, 1% comes as urine. At the end there, we know that the principal cells like antidiuretic hormone and the principal targets guys at the collecting duct of the antidiuretic hormone, aldosterone, these will collect, and the end drop there is 1 ml. So we have 1 ml per minute. Okay, right? 1 ml per what? Per minute. So from that 1 ml per minute, what are we trying to say there? 1 ml per minute. Follow me very well there, dear friends. Okay, that is urine formation. Per minute, 1 ml is formed. So if I want to know how many mLs then per day are there, I'll just go back to mathematics. 1 ml, how many minutes makes an hour? 60. So times 60. How many hours makes 1 day? 24 hours times 24. And equals about 1040 mLs. That is a super normourea. Definitive normourea. Okay. So that's why a good clinician will be very happy with just 500 mLs. All right, it's okay, it's normal. A very good clinician will be very happy to say, oh, 1440 is okay. An excellent clinician will be very, very, very excited if normourea is above 1500. Okay, so usually normourea, it is 1000 from 500 mLs, okay, 500 mLs to 3500 mLs per 24 hours. It's okay, it's not a problem. Okay, that's normourea. Then when it comes to polyuria, more than 3500 mLs, more than 3.5 liters per 24 hours, that is marked polyuria in clinical practice. Very significant. Anuria simply means less than 100 mLs per 24 hours. That is per day. Now, sometimes you may be reading your books and they'll tell you no urine. So what does no urine simply mean? Does it mean that there's no urine formation? No. There may be an obstruction, total obstruction. So if you don't see any urine in the urinary bag, okay, you have to think of there is what? An obstruction. So you may be either the fluid is less than 100 mLs per 24 hours, or absolutely you don't see any urine there. That is anuria. Okay. Oligouria, we are actually saying less than 500. Okay. So less than 500. Now listen carefully here. We have seen it marked significantly when it is less than 400. That's why most of your books will tell you now less than 400 mLs. Okay. Okay. But we know that just less than 500 is still oligouria. Okay. But now we have got a specific term that between 400 to 500, we are calling it non-oligoric. Okay, non-oligoric. So less than 400, it is marked oliguria. All right, I repeat, from 400 mUs to 500 mUs, that is non-oligoric, non-oliguria stage. Below 400 mUs, it's marked oliguria. All right, so we have addressed one component on normal urine output, which I said 0.5 to 1 mu per kg per hour. That's more appropriate. But I've explained also based from the cardiac output on the urine formation, you can also still address, and this is what I've tried to explain. Then we come to creatinine, okay? Serum creatinine. So serum creatinine is dependent on sex. So the males, okay, it is 53 to 106, okay, micromoles per liter. That is for males. For female, it is 44 to 97, okay. So for males, it is 53 to 106, okay, and for female, it is 44 to 97, okay. Then we come to normal urea. Then there is also a very important question here. Which one do you think is more dependent in helping you quickly diagnose this acute kidney injury? Which is more specific? Okay, which is more definitive between creatinine and urea? So you find that actually it's creatinine. Creatinine is very sensitive to injury. Urea is non-specific. Okay, you go to the party, dance, enjoy the birthday, and eat a lot of red meat, eat a lot of red meat, and then you have a lot of proteins, and these proteins are broken down. When these proteins are broken down, actually you have an end product of urea. So it may also be depicted after enjoying a wedding or a birthday party. All right. And then also you may not take enough fluids. Okay. You may also find that actually there may be concentration of urea which may show by an increment of a number. So that's why we are saying it's not much specific. So the most liable there is creatinine. Sometimes we also talk about what is normal burn. So okay, so the burn there we're talking about blood urea nitrogen. So by the way, I haven't told you the range for urea. So urea is 2.5 to 7.2. So 2.5 to 7.2. What are the units here? That is millimoles per liter. Okay. What of blood urea nitrogen? There it is 3.6, okay, to 7.1 millimoles per liter. Okay. So hope you have understood, and hope we are moving together as we proceed now to another area. Now that we have discussed, that we have addressed that our diagnosis here, our likely diagnosis actually, it is acute kidney injury. Then it is very important that I would love also to explain on how would you define acute kidney injury. So I'll give you good definitions, and you're able to choose varieties. You can also define acute kidney injury as an acute deterioration of kidney function leading to 1. Retention of nitrogenous or nitrogen waste products. Number 2, dysregulation of fluids, electrolytes, and acid-base balance. Okay, that you can also define acute kidney injury like that. Okay. Then you need to know that acute kidney injury actually is not a single disease. It's not a single condition. It's a syndrome. Okay. So you may also say it's a syndrome that is characterized by a reduction of renal function. Okay. Over hours to days. Okay. Causing an accumulation of what? Nitrogen products in the blood. and we are calling that azotemia. Okay, so I repeat, acute kidney injury is a syndrome that is characterized by a rapid decrease in renal function, okay, over hours to days, causing accumulation of nitrogen waste, okay, in the blood. In other way around, you may also say it's an acute, it's a syndrome characterized by a rapid renal function over hours to days, secondary to azotemia. It is, you are okay. All right. Now, let me now go further on the syndromes. What are these characteristics that you're supposed to know? Pick your pen. Okay. Number one, we are talking about, let me write here. Because these are very, very, very important. Pick your pen. Number one, this AKI. Okay. This AKI we are talking about is characterized by number one, there is rapid reduction of glomerular filtration rate. The one that I said, that is hours to days. Number two, you may also note that there is actually retention. These are the characteristics of this syndrome. There is retention of what? Nitrogen wastes. Nitrogen waste due to failure of excretion. Okay. Number three, you may also find that there is disturbance. Very, very important. There is disturbance in extracellular fluid compartment. And you know when I talk about this disturbance in extracellular fluid compartment, what is disturbed? Once the extracellular fluid compartment is disturbed, then I know that the cardiac output is disturbed. Once the cardiac output is disturbed, I know that the blood pressure is disturbed. I also know once the cardiac output is disturbed or is depleted, I also know that the glomerular filtration rate is what? Is disturbed. Okay, that's very important too. Then 4, okay, there is also disturbance. In what? There is disturbance in as electrolytes and acid base homeostasis. That's balance. Okay, homeostasis. That is balance. So these are very, very, very important to take note. Then there's something that I also am supposed to ask you. What's the difference between azotemia versus uremia? Okay. Let's hope someone is not telling me uremia is the presence of urea in blood. And if that is your answer, then I'll ask you, then what if we talk about the no? Why are we having? Why do we discuss on the normal range of urea? So if we say normal urea in blood, is that not urea present in blood? So if in medicine practice, we want to know at what point do we call it uremia. So let's talk about what azotemia is. So azotemia is an increase of nitrogenous waste products in the blood. And what are these nitrogenous waste in the blood that we're talking about? We are talking about blood urea nitrogen, okay, and creatinine. Now, the increase of these nitrogenous waste products in blood without symptoms. So azotemia is asymptomatic. Okay? And the other thing that you're going to see is that the glomerular filtration rate is 20 to 35% of normal. Okay? So it's operating at 20 to 35% of the normal glomerular filtration rate. Okay? And that is called what? Azotemia. So in other way, azotemia, you can detect it based on the laboratory results. So the lab results will be normal. What are those specific lab results? The blood nitrogen, urea nitrogen, and creatinine. So these will become abnormal. They will increase. But the patient is not giving you clinical features of acute kidney injury. Okay? We call that azotemia. Now, when we talk about uremia, uremia simply means now is deterioration of renal function that is associated with the symptoms. So what's happening here is that now here there is abnormal, okay, abnormal lab results, which I've mentioned there, okay, which is BAN plus creatinine with symptoms. And you find that the glomerular filtration rate, very good multiple choice question, it is less than 20% of normal. Okay. So that's the difference. So uremia, it is symptomatic plus abnormal lab results. So there will be now signs and symptoms, the features of renal failure present. Okay. And you need to be reminded that this AKI, okay, we used to call it acute renal failure. And there's a reason why we are not calling it acute renal failure, because acute renal failure is just trying to direct its axis straight to uremia and leave in what? Azotemia. So acute kidney injury is just a reminder that as clinicians, there's a responsibility for early diagnosis to avoid all the complications that may arise from this condition. All right. All right, let me now try to delete. Hope you have been doing that. So what is what I was trying to say? You can also say acute kidney injury is an abrupt deterioration in parenchymal renal function, which is usually but not invariably reversible over a period of days or weeks. Okay. You may also say it is a rapid reduction in kidney function over hours to days as measured by serum, urea, and creatinine, and leading to failure to maintain fluid electrolyte and acid-base homeostasis or balance. In clinical practice, such deterioration in renal function is sufficiently severe to uremia. I've explained this. It's very difficult. Mostly early azotemia is missed. That's why when you're ordering every investigation, interpret the investigations. Try to get a picture there. Then you combine that picture with your history taken and your physical examination. Don't just be looking for diseases on clinical chemistry results. Okay? So this is what actually happens. Let's go to diagnostic criteria. Very, very, very important. Let's now go to diagnostic criteria. Before we go to the diagnostic criteria, sorry, there's something very important that I have to tell you. That also there is what we classify also AKI. We classify AKI based on the urine output. Okay. So we have three classifications. So we have anuric AKI, that is when urine output is less than 100 ml per day. Okay. Then 2, we also have what we say oligoric AKI. This is when the urine output it is less than 400 milliliters per day. Okay. Then we also have non-oligouric AKI. This is when the urine output it is equal or above 400 mils per day. So this ranges from 400 to 499 mils per day. Very important. Immediately we reach 500, it is normouriah. Okay. So very important, need to know. So anuric simply means there is anuria there, and we said about anuria. Oligouric, there is oliguria mark there, but non-oligouric, it's not in that range that we talked about. So it's in the range of 400 to 499. Okay, 500 is normouriah. That's adopted clinically. Okay, but an excellent clinician will be very happy to a patient whose urine output is at least 1,500 and above. Okay, let's go next to the diagnostic criteria. That is very important. Okay, so diagnostic criteria, this is now what we are going to discuss. We have KDIGO. Okay, where we're going to look at KDIGO, diagnostic criteria, and staging. We also look at AKI, diagnostic criteria, and staging. Okay, so what is KDIGO? When we talk about KDIGO, KDIGO simply means kidney disease improving global outcome. Okay, so we'll be looking at this one. So now let me discuss in terms of the diagnostic criteria. So I'll begin with diagnostic criteria, then later I'll be explaining on the staging for each. So concentrate, that's very important for part of the examination as well. So this is kidney disease improving global outcome. So what's the diagnostic criteria for AKI using KDIGO? Okay, very important. Number 1, for us to diagnose, we have to consider these things. Number 1, all right, from here, it is when serum creatinine, okay, serum creatinine is equal or above 0.3 milligram per deciliter. Okay, that is within 48 hours. Okay, or so any of these two is diagnostic of acute kidney injury using the KDIGO. So serum creatinine, okay, of equal or greater than 0.3 milligram per deciliter within 48 hours is the diagnostic. Or there is increase of serum creatinine base from the baseline 50% within 7 days. Okay, it is also diagnostic. So what it means here, if creatinine, let's say it is 2, let's say it is 2 milligram per deciliter as an example, then within 7 days you test, then it becomes 3 milligram per deciliter. Then this is a diagnostic. That's what we mean, because 50% of 2 is 1. So 2 plus 1, we get 3. Okay, so the 50% that is added, that is increased, that's what we mean by equal or more than 50% from the baseline within 7 days is diagnostic according to KDIGO. Then we can also use urine output. Okay, so the urine output of less than 0.5 mils per kg, okay, per hour for 60 hours. Okay, and that is diagnostic. So that's a diagnostic criteria of the kidney disease improving global outcome. So we have 3 diagnostic criteria. Okay, so each criterion is diagnostic. So any of those is diagnostic. So number 1, serum creatinine greater or equal 0.3 milligram per deciliter within 48 hours is diagnostic. Or there is serum creatinine increase more than 50% from the baseline within 7 days. That's diagnostic. Or using the urine output less than 0.5 mils per kg per hour. Remember, this is already addressing oliguria. And this time, this patient is in the ward, is in the ICU actually, and you are checking within 6 hours from a time of admission, and that there's still oliguria. That is critical. So I'll come and explain staging. Let's go to AKI. What is AKI? That is acute kidney injury network. Acute kidney injury network. So what's the diagnostic criteria for acute kidney injury network? Okay, so let me change the color of the pen. Okay, what is the diagnostic criteria? So the AKI. Okay, so number 1 is the same with the KDIGO. Take note here. You find that it's the same creatinine. Serum creatinine is the same. It will increase 0.3 milligram per deciliter within 48 hours. Just the same. Number 2, serum creatinine increase more than 50% from the baseline within 48 hours. Number 3, using the urine output is less than 0.5 mils per kg per hour for 60 hours. So what are you able to take note there? You find that actually there is something very important to take note. Okay, the difference there, the only difference between AKI and KDIGO, it is on the baseline aspect. Okay, so on the baseline, it is within 48 hours for AKI, whilst in KDIGO, it is within 7 days. So for the exam purpose, it's very important to take note. Okay. All right, let's go to the next one. So we have dealt with the diagnostic criteria there for AKI. Okay. And we have noted the difference. Then we come to the next one. Wow, the rifle. It's a must know. That's why it is in this. Very important. So the rifle, we are talking about R there, which is the risk. We are talking about I, which is injury. We are talking about F there, which is failure. And we are talking about the L, which is loss. And we are talking about the E there, which is the end stage kidney, the end stage kidney damage or disease. Okay. So this is the risk, the rifle. So remember, just remember a rifle, which is a gun. Okay. Now, what do we talk about the aspect there now? I've talked about the risk, and I'll come and now talk about the diagnostic there, just as I'll talk about this on this one, because there's a reason why I'll explain it at the end, because it has got a very good relationship with the KDIGO. All right. Let's now proceed to the next and begin now to go in detail. Relax. Okay, stretch yourself. Stretch, smile. Say, I will make it. This time I'm making a distinction. If there's someone there actually who has been writing either internal medicine, okay, and has been struggling with passing internal medicine, either intermediate or fine, this time say, I'll make it. Smile. All right. So making it so clearly, just continue to attend these lectures. Let's begin with this now. We're now saying KDIGO. Let's begin. KDIGO. Wow, that is KDIGO. What did we say KDIGO is? It is kidney disease improving global outcome. We begin. So on this aspect now, I'm talking about staging. Okay. So the KDIGO has got 3 stages. Okay. So I'll be explaining stage 1. Stage 1. What do you expect on stage 1? What is there on stage 1? Let's move together. Take your pen. Okay. So stage 1, number 1, serum creatinine. So serum creatinine, stage 1, it is increased 1.5 to 1.9, okay, from the baseline within 1 week. Okay, that is stage 1. Or serum creatinine increases more than 26 micromole per liter, okay, within 48 hours. That's still stage 1. Then if we are using urine output that is less than 0.5 mL per kg per hour for 6 hours. Okay. So what does that simply mean? The KDIGO, usually we are using serum creatinine and urine output. Okay. So if we're using serum creatinine and it increases serum creatinine increases 1.5 to 1.9 from the baseline within 1 week. Okay. Within 1 week, then that is in stage 1. Okay. Or serum increases more than 26 micromole per liter within 48 hours. Or the urine output is less than 0.5 mL per kg per hour for 6 hours. That simply means that is stage 1. Okay. Stage 2. So stage 2, serum creatinine. Okay. It is 2 to 2.9. Okay. Times from the baseline. Okay. So when it increases from baseline 2 to 2.9, sometimes it's not harm for you to write 2 to 3. times from the baseline. Okay, that is in stage 2. If we are using urine output, it is less than 0.5 mils per kg per hour for 12 hours. So the patient has been admitted for 12 hours, still oliguria is not improving, still marked oliguria within 12 hours. Then that patient is in stage 2. Serum creatinine increases from 2 to 2.9, okay, more than 2 to 2.9 from the baseline, then that is stage 2. Okay. Then we come to stage 3. So stage 3, forgive me, I'll use a red color because it is now the most common is usually seen. Okay, stage 3. So stage 3, what is there? Number 1, okay? Number 1, serum creatinine, okay, is more than 3 times from the baseline. Okay, to increase more than 3 times from the baseline. So serum creatinine will increase more than 3 times from the baseline. That is stage 3. Okay, or 2, serum creatinine increasing, okay, serum creatinine increases to 4 milligram per deciliter. That simply means that it is about 353.6 micromole per liter. Okay, with acute rise, okay, with acute rise of more than 40 micromoles per liter. That actually it is in stage 3. Okay, or the patient requires initiation of renal replacement therapy, which is also abbreviated as RRT. So when you find it RRT, you're talking about a renal replacement therapy. What is this renal replacement therapy? That is actually dialysis. That is stage 3. Or the patient, especially one is less than, okay, less than 18 years. Those who are less than 18 years, the estimated glomerular filtration rate usually reduces to less than 35 mils per minute, all right, per 1.73 meters squared. If we're using the urine output, that is less than 0.3 mils per kg per hour for 24 hours. Okay, And if there is anuria, anuria it is for 12 hours. So this is how we stage critical. Hope now you have gotten a very good concept and you were following. So stage 3, what did we say? Stage 3, we are saying that there is increase of serum creatinine more than 3 times from the baseline. Okay? Or this serum increase, the serum creatinine increases to more than, equal more than 4 milligram per deciliter. That's giving us about 353.6 micromoles per liter, with acute rise of greater than 40 microliter, micromole per liter. Okay, that is diagnostic. So sometimes even if you write 350, we still give you a mark. 350. Yes, it's still in stage 3. Then if this patient is less than 18 years, the estimated glomerular filtration rate actually reduces to less than 35 mils per minute per 1.73 meters squared. Then when we come to our urine output criterion, here we find that actually it is less than 0.3 mils per kg per hour for 24 hours. And if there's anuria, we have now known what anuria is, and it is about 12 hours. Okay. Now, there's something that I need to talk about. It's on the stage 3. There's something nice that I would love to talk about. So let me try to erase and show you what I want to talk about. It's an aspect of same stage 3. I'm trying to do this because it is very important for examination aspect. Okay. So stage 3, specifically I want to talk about replacement, renal replacement therapy, which is dialysis. The question that you may meet there is, what are the indications of dialysis? What do you do? Remember your teacher. A, E, O, U. A, E, O, U. So just sing this song. But of course, don't sing it in the exam room. All right? Yes. A, E, O, U. And what is there? Talk about acidosis. Talk about electrolyte imbalance. Okay? Talk about ingestion. That is toxication. Talk about fluid overload. Talk about uremia. Just remember this song. Okay, remember your teacher, and those are the indications. And you get good marks there. All right. Let's proceed to the next criterion. That is AKI criterion, which we have known acute kidney injury network. Right. So we are now going straight to the staging. So it also has 3 stages, just like Kidigo. Okay? It also has 3 stages, just like Kidigo. So stage 1. So stage 1 for Akin, just like Kidigo, there's increased serum creatinine of equal more than 0.3 milligram per deciliter. Okay, that is stage 1. Or the baseline serum baseline is 50 to 100%. Okay, that is the baseline of serum creatinine. Or using the urine output less than 0.5 mL per kg per hour for 6 to 12 hours. So the difference with the staging for critical is just a range. Critical just tells you 6 hours. But the AKI says no, from between 6 to 12 hours. That is still stage 1. Okay. Then stage 2. Stage 2. Stage 2, there's increased serum creatinine. Okay. That is equal or more than 100%. Okay. And if we move by the way of urine output, it is less than 0.5 mL per kg per hour, which now goes from 12 to 24 hours. Remember, for KidneyGo, it's just 12 hours. But for acute kidney injury network, they are saying when we have this oliguria from 12 hours to 24 hours, still in stage 2. Okay. Then we go stage 3. Allow me to change the color still. Okay. So for stage 3, okay. So number 1, what is there? There's increased serum creatinine more than 200% baseline. Okay. Or number 2, there is actually also increased serum creatinine of more than 0.5. Okay. Usually you can just say by 0.5 milligram per deciliter to equal or above 4 milligram per deciliter. So that is in stage 3. Okay. Or 3.3 there. We may also talk about the aspect of urine output. Okay. So the urine output there, it is less than 0.3 mL per kg per hour. That is for 24 hours. Okay. So that's the difference. This is just talking about the same. The only differences are stage 1 and stage 2, which are in the range. And remember, when there is anuria, there, it is for 12 hours. And the fourth one, okay, initiation of RRT, that is renal replacement therapy. And I said this is dialysis. Another our song again. A E O U, A E O U, A E O U, A E O U. So you remember acidosis, electrolyte imbalance, fluid overload, uremia. There you go. And I injection. So A E O U. Okay. Always remember, sing that song because they'll ask you the indications of dialysis. Right. Let's proceed to the next one. Wow, now we come to the rifle. Okay. So what is rifle? Yes, we said about risk, injury, failure, loss of function, end-stage kidney disease or damage. Okay. So now, what are we supposed to consider when we're talking about the rifle criteria? So the rifle criteria, that is very important to take note. It is basing on the aspect of three things that you have to consider when you're talking about the rifle criteria. What are those three things? Number one, we are talking about based on the glomerular filtration rate. 2, based on serum creatinine, and 3 is based on the urine output. The other thing that's supposed to know here is that the first stages. So rifle, other thing that know that rifle it has 5 stages, as you can see. And now the first 3 stages, they are just the same with the kidney disease improving global outcome. KDIGO, they are just the same. So you have to take note. That's why rifle is a must to know because it combines KDIGO and have some additions for the rifle. That is very, very, very what? Important. Okay. Let's begin with now what rifle criteria is. So I'll be looking at each stage. Okay. So the first thing, the risk, know that it is the same as KDIGO stage 1. So what's there? We talked about, I'll talk about now glomerular filtration rate. It will increase more than 25%. Okay, that's number 1. Number 2, if we are basing on the serum creatinine, the baseline increases, serum creatinine increases 1.5 to 1.9 baseline times from the baseline within 1 week. When we come to using the urine output criterion, the urine output is less than 0.5 mils per kg per hour, okay, for 6 hours. So that's in stage 1. Okay. Then we go to stage 2, injury. Just the same with KDIGO stage 2. So let's look at what is on the aspect of glomerular filtration rate. It will increase more than 50%. Rather, it will decrease. Sorry. Number 1, instead of increasing, the glomerular filtration rate actually decreases by more than 25%. Then, under stage 2, it decreases by more than 50%. Then 2, we look at the serum creatinine. Okay, it will increase from 2 to 2.9. The range of 2 to 2.9 times from the baseline. Okay, and if we use the urine output, it is less than 0.5 mils per kg per hour for 12 hours. Okay, so that tells you that is in what? Stage 2, which is injury. Okay, so meaning at stage 2, now there is marked injury. At stage 1, those are just the risks. If we don't address those risks, what will happen? That there will be what? There will be an injury. Okay. Then let's go to failure. So failure, that is stage 3. So it's the same as KIDIGO, stage 3. Okay. So let's look at our parameters there. So glomerular filtration rate actually decreases here more than 75%. And when we look at serum creatinine, okay, it is more than 3 times baseline, to increase more than 3 times from the what? The baseline. And when we come to the urine output, okay, so the urine output under stage 3, you discover that actually it is less than 0.3 mils per kg per hour for 24 hours. And if there is anuria, what do we say? This is a golden rule now. So if there is anuria, it is for 12 hours. Now, listen carefully. Let me try to put up another thing here on the aspect of creatinine. So creatinine also, it may be another creatinine if it is more than 350 micromoles per liter. Okay, with acute rise. Okay, with acute rise of greater than 40 micromole per liter. That is still in what? In stage 3. Okay. Also, if there is also in the aspect of replacement, insertion of renal replacement therapy, that is dialysis. Okay, that's still stage 3. So if there is that insertion now, the patient is put on the dialysis machine or the dialysis, then we know that now that is in stage 3. So again, let's sing our song. Okay, let's sing our song. It's A, A, E, O, U. I'm sure you will never forget whenever they ask you on the indication. So let's sing together as a break. A, E, O, U. A, E, O, U. A, E, O, U. Wow, you remember? Okay, that is acidosis. That is electrolyte imbalance. That is ingestion of toxics. That is overload. That is uremia. These are the indications. So whenever I'm bringing RAEOO, I'm talking about the renal replacement therapy, dialysis, to remind you always on the indications. Now, take note that this is the difference part when it comes to the aspect of what? The aspect of the first 3, okay, which are actually trying to measure, okay, the severity. Then the last 2 now, the loss of function, the end stage damage, is now looking at the outcomes. So this is where I end. So now, on the loss of function, what are we talking about here? Okay, so what are we talking about here? So what we are talking about is that, number one, okay, what we're talking about here is, number one, there is need. What simply means here that there is need for renal replacement therapy for 4 weeks. Okay, what does that simply mean? What do we mean if we say there is need for renal replacement therapy for 4 weeks? Simply means that acute kidney injury here has persisted. Okay, so there is persistent of acute kidney injury. For what? For how long? For 4 weeks, which is 1 month. When it comes to end stage kidney disease or damage, what does that simply mean? Okay, simply means that there is need for renal replacement therapy for 3 months. That simply means that actually there is persistent renal dysfunction or persistent renal failure for what? For 3 months. Okay, so there is persistent renal failure for how long? For 3 months. That's why there is need for renal replacement therapy for 3 months. Hope this is very, very easy for you and very, very, very important. Now, let me share something also in addition, as now we're coming to conclude our lecture. Okay, so let me try to put up something that's very important as we observe this patient. We need always also to talk about the phases of acute kidney injury. So there are 4 phases of acute kidney injury. Okay, so let me try to do this. Sorry. Let me put it nicely. That is very important. Okay, there are 4 phases of acute kidney injury. That's very important to take note. So phase number 1, it is called initiation. Okay, so there is initiation. So under initiation again, it is also very important that there are some parameters that we have to consider there. We have to talk about the duration. Okay, we have to talk about the urine output, and we have to talk about the serum creatinine, and we have to talk about the treatment. Okay. Okay. So initiation, when we talk about initiation, so when it's beginning, that is the first 2 days. So the duration is the first what? 2 days. So when you check the urine output here, it is normal. Okay, so the urine output there is normal. Let me now here try to practice a good way. I have to consider the aspect of colors. Okay, so when we are talking about the aspect of this, we have to talk about the insertion. So this is a stage where it's able to be missed. So we are saying the urine output there is normal, okay, and the serum is normal, and there's no need of what? Treatment. Or what you do there is you observe. The second phase, that is called oligouric. Okay, Now there's established, it is also known as maintenance. Okay, so the duration of this oligouric, usually it is 2 days to the second week. Okay, and when you check on the what do you think now? If we talk about the oliguria, what happens to creatinine, serum creatinine? Of course, serum creatinine is going to what? To increase. And when serum creatinine has increased, simply means that the urine output will do what? Will decrease. And here, what will happen? Now you may need treatment for renal therapy. Renal replacement. What therapy may be there based on the observation. And what happens now is that the issue there is that you may also restrict. You may restrict the issue of fluids. So here you restrict the fluids. Okay. So that is on phase 2. So on phase 2, what have we said? Oligouric is what is there, the stage, the maintenance, and on the duration now, 2 days to second week. That's how it will last for 2 days to the second week, and then the urine output is going to decrease, and then the serum creatinine is also going to increase, and the patient may require renal replacement therapy, and at this point you have to restrict the fluids. Okay, let's talk about phase 3. So phase 3 now, the patient now has reached what we call diuretic. So the diuretic now, what happens here is it lasts now 2 weeks. Okay, 2 weeks to 4 weeks. Okay, and then what will happen here? The urine output is going to increase. So if the urine output increases, what happens to the serum creatinine? Serum creatinine is going to decrease. And here now, what you do now, what you need there is fluid. Actually, this patient now requires fluid. Okay. And the fourth stage, that is called resolution or recovery. Okay. So under this one, the duration is more than 4 weeks. And here, when you check on the urine output, it is normal. Check on the serum creatinine, it is normal, and no need of what? Treatment. So that is the phases. So you have to remember that they are 4 phases of acute kidney injury: initiation, oligouric, maintenance, diuretic, and resolution. So that's what we need to remember. And in the actual practice, actually, where it is abnormal there, we have to use red. Okay. Where it is abnormal there, we have to use red. Here it is normal. Blue is okay. Okay. So this is the dangerous part that we have to actually manage. Hope you have been looking at this. Hope this presentation has been so helpful to you that at least you are able to answer questions that are relating to this. And quickly, complications that this patient may encounter, just to list them, as I say that in part 2, that's where I'll come and explain. So some of the complications that at least we should remember, that will come and go in detail, is anemia, and we'll come and look at what type of anemia is actually found in acute kidney injury or chronic kidney injury. Okay. The other complication that is there is acidosis. The other complication that is there also is hyperkalemia. And this is a very, very, very important complication. Okay. And then the other one is hyponatremia. And the fifth one is pulmonary edema. The sixth one, you may talk about shock. All right. So this is about, we have covered the KIDIGO criteria, we've talked about the AKI criteria, we have talked about the rifle criteria. Okay. Case study 2. A 54-year-old diabetic man is receiving medical therapy consisting of oral aspirin, beta blockers, ACE inhibitor, and intravenous nitroglycerin for treatment of his angina and hypertension. He undergoes coronary angiography, which reveals no significant stenosis. He is normotensive. His fundoscopic examination shows dot hemorrhages and heart exudates, evidence of diabetic retinopathy. In this setting, the baseline elevated creatinine level on admission likely represents diabetic nephropathy as well. His creatinine level has risen to 2.9 mg per deciliter from 1.6 mg per deciliter. On admission, by the next day, he has become oligouria. So he has become oligouric. Okay. A. What other information would you want to inquire from history? B. What are your differential diagnoses? C. What is the most likely diagnosis? And D. Discuss your management plan in detail in clinical setup. Wow, this will be answered in part 2. So the next is part 2. Thank you very much. Hope you have enjoyed the presentation. Okay. So hope you have enjoyed the presentation, and please don't miss part 2. And there are questions that have been uploaded on the system. Just more questions to talk about. Multiple choice questions, true or false, matching, one way to answer, some more scenarios that's supposed to attempt yourself in the system. So all what you need to do is follow the number that you see at the end of the session. You can call, text, or telegram and access full package for revision. All the best. Congratulations.
What